Sickle cell disease is a common hereditary hemoglobinopathy caused by single point mutation in beta globin gene. A GAG codon is mutated to GTG, resulting in substitution of normal charged hydrophilic glutamate residue with the hydrophobic valine residue. Glutamate is replaced by valine. As a consequence, the subtle amino acid change dramatically altered physiochemical properties of resulting sickle hemoglobin, setting the stage for polymerization. In the molecular pathogenesis, the mutation in the 6th codon of beta globin gene on chromosome 11, replacement of glutamic acid with valine. Whenever these patient or these individual exposed to hypoxia or deoxygenation, this will result into the polymerization of HbS or sickle hemoglobin into long needle-like structure and result into RBC cytosol liquid to viscous gel. Liquid cytosol convert into viscous gel. Repeated or persistent hypoxia result into the formation of needle-like crystal, and they damage the RBC membrane. RBC membrane damage will result into calcium influx and potassium and water efflux, and ultimately irreversibly sickle cells will be there. Irreversibly sickle cell formation will be there on persistent hypoxia. Normally in a beta globin gene, a glutamate is present on the 6th codon. In sickle cell, there is glutamate is replaced with valine. These individuals with HbS or sickle hemoglobin exposed to hypoxia result into the formation of fiber, needle-like fiber formation, and these damage the RBC membrane and result into calcium influx and potassium and water efflux and dehydration of the cell. Long-standing hypoxia result into permanent sickling of the cell. Irreversibly sickle cell are phagocytosed by various mononuclear phagocytes in spleen or bone marrow, result into extravascular hemolysis, which manifests as hyperbilirubinemia and gallstone. These RBCs are fragile due to membrane damage and may result into intravascular hemolysis and release free hemoglobin into the plasma. This free hemoglobin binds with the nitric oxide and decreases the level of nitric oxide, which result into increased platelet aggregation and altered vascular tone, and play an important role in development of microvascular occlusion. Based on the site, this microvascular occlusion causes ischemic tissue damage like acute chest syndrome in lung, dactylitis and pain crisis in bone, acute congestion and autosplenectomy in the spleen, and may result into the stroke when brain is involved. So the mechanism behind vaso-occlusion in sickle cell anemia or sickle cell disease is sickle cell express increased adhesion molecule and they decreases the nitric oxide due to free hemoglobin, which causes increased platelet aggregation. Both of these mechanisms will play an important role in development of vaso-occlusive crisis. These sickle cell have damaged membrane and they express increased adhesion molecule and have increased stickiness for endothelium. Whenever there is a slow flow, or particularly in inflamed site, spleen, bone marrow, there is in high chances of vaso-occlusion. Now, what are the factors affecting or influencing sickling? So MCSC, mean cell hemoglobin concentration. Increased MCSC increases sickling because of dehydration. pH acidosis shifts curve to right side and promoting deoxygenation and increases the sickling. Fetal hemoglobin and adult hemoglobin, they inhibit HbS polymerization, and that's why decrease the sickling. Coexisting alpha thalassemia will result into decrease MCSC, and that's why reducing the severity of sickle cell disease. And on the other hand, if alpha chain is low, so there is no alpha chain available for pairing with the beta chain, so ultimately decreases the risk of development of sickling. Transit time. Sluggish flow promotes sickling. Sluggish flow are particularly present in spleen, bone marrow, and inflamed sites. As we have discussed, sickle cell have more adhesion molecule, and they have increased tendency to stickiness. Morphology and finding on peripheral smear. RBCs are sickle shaped RBC or holly leaf shaped RBCs. They can be target cell due to dehydration. Howell-Jolly body, small nuclear remnants indicate functional splenia. Bone marrow can show erythroid hyperplasia due to hemolysis. On X-ray, crew-cut appearance of the prominent skull and prominent cheekbone can be seen. Crew-cut appearance is also seen in thalassemia. These are the peripheral blood smear finding. Target cells, Howell-Jolly body, these are the nuclear remnants. Reticulocytes is also increased due to because of the hemolysis. There is increased erythropoiesis. So reticulocytes release in the peripheral circulation. Clinical manifestation or the various crises involved in or seen in sickle cell disease. Very important is vaso-occlusive crisis. This is most common and causes wound pain, dactylitis, also known as hand-foot syndrome in infants, acute chest syndrome, manifest as fever, chest pain, pulmonary infiltrate. Leading cause of death in adult is acute chest syndrome. Sequestration crisis, massive RBC trapping in the spleen and result into sudden splenomegaly and hypovolemic shock, which is common in children. So splenomegaly and hypovolemic shock is common in children. Acute chest syndrome is the leading cause of death in adults. Aplastic crisis seen in individual of sickle cell disease, which is triggered by parvovirus B19 infection and result into sudden drop in reticulocyte. What are the systemic complications seen in sickle cell disease? Spleen show early congestion, chronic infarction, and autosplenectomy. Spleen reduced to fibrous nubbin by the adulthood. Infection, increased risk of encapsulated organism, Streptococcus pneumoniae or Haemophilus influenzae due to asplenia. Kidneys, there is hyposthenuria, inability to concentrate the urine due to renal medullary damage. Bones show increased risk of salmonella osteomyelitis, and due to extravascular hemolysis, formation of gallstone, pigment stone. Diagnosis and screening of sickle cell disease. In the screening, use solubility test or sodium meta-bisulfite test to see the sickling of RBC. Gold standard is hemoglobin electrophoresis or HPLC, which show HBS, increase HBS. Prenatal diagnosis, DNA analysis by amniocentesis, and in the newborn there is newborn screening, which is routinely followed in many healthcare sector or setup. So for screening, sodium meta-bisulfite test or sickling test. Gold standard is hemoglobin electrophoresis or HPLC. Prenatal screening, DNA analysis by amniocentesis, and newborn screening from the heel stick screening. Management of sickle cell disease. Hydroxyurea is the mainstay of treatment of sickle cell disease. Hydroxyurea increases Hb level and has anti-inflammatory effects. Hbf decreases the polymerization of HbS and ultimately decreases sickling. L-glutamine reduces oxidant stress and pain crisis. Supportive treatment is hydration, analgesics, prophylactic penicillin at the age of 5 can be given. Vaccination against encapsulated organism, as due to aspiria, infection of encapsulated organism can be increased in sickle cell disease. Definitive and emerging treatments are hematopoietic stem cell transplant, and new treatment modalities are gene editing, reverse hemoglobin switching to produce HbF. Now we will see the mechanism of falciparum malaria protection in sickle cell individual. Normally, the malaria parasite decreases oxygen or consume oxygen inside the RBC and cause a condition of hypoxia or deoxygenation, which induces sickle cell formation, and these sickle cell with parasite are cleared by the phagocytes of the spleen. So this decreases the load of parasite. And the second mechanism is normally RBC with the help of PFEMP1 protein, which is a parasite made protein, form a membrane node which increases the adhesion of these RBC to the endothelium of cerebral vessels. But in sickle cell there is impaired knob formation and ultimately decreases the adhesion of these RBC or sickle cell and decreases the risk of development of cerebral malaria. So by these two mechanisms, sickle cell individuals are protected against falciparum malaria. One is the malaria causes hypoxia and promotes sickling, and these sickle cells are cleared by the phagocytosis and decreases parasite load. And the second mechanism is sickle cell has impaired knob formation and ultimately decreases cell adhesion. So the incidence of cerebral malaria is decreases in sickle cell. Now we'll see the important points of a sickle cell disease. Mutation at the 6th codon of beta globin on chromosome 11. Glutamate is replaced by valine. The sickling is commonly caused by or triggered by hypoxia, acidosis, dehydration. Autosplenectomy in adults is or children is seen due to vaso-occlusive crisis. Infection of or increased risk of infection with encapsulated organism like Streptococcus pneumoniae, H. influenzae, and bone infection with Salmonella is there. Crooked appearance seen on the skull X-ray, and hydroxyurea is the mainstay of treatment.